starting next week when we start accessing readings that are available to you through Blackboard. I've also put 3 copies of She and Sing, the course textbook, on Rush Reese Reserve. So you can get that book on 2-hour reserve in the standard form, in the standard way, if you don't want to purchase or rent a copy of the book from the Barnes & Noble bookstore, which has copies available for those who want to do it that way. Any questions about any of that? Okay. Well, let's now turn to the handout. Everybody have a copy of the handout? And here is the context. I mentioned last time that the WHO in about 2000 came out with a ranking of health systems, all the health systems for which they had data, and noted that the US was ranked, I said, 38th. I actually misspoke. The WHO ranking was 37th, and the 38th place was occupied by Slovenia. Notice how we're in close competition with Slovenia. Perhaps that explains Donald Trump's fascination for Melania, whose home country is Slovenia. I doubt it, but anyway, it's worth noting. In fact, if you look on page 3 of the handout, you'll have some comparisons that are derived from the most recent and thorough analysis of the U.S. healthcare system and comparative rankings that I know of. There are others that cover aspects of these comparisons, but nothing as comprehensive. This is the American healthcare paradox, why spending more is getting us less, by 3 authors who are authors commissioned by the Institute of Medicine, our most prestigious medical and health policy body. As I've said before, it's in Washington. It's appointed with members appointed with great rigor. There are many Nobel laureates who are members of the Institute of Medicine. It's officially a part of the U.S. Academy of Science, which is a very high recognition for those in the sciences. This is the medical equivalent. And this very prestigious and distinguished and careful body produced a report of which you see some of the data based on 2007 OECD data. OECD is an abbreviation for those most advanced economic countries in the world. There's always going to be a time lag, sometimes longer than a decade, between the data and the analysis, because it takes a long time for data to be collected, analyzed, scrubbed, made rigorous, and to perform the analysis. So there's always going to be a bit of a time lag, but this is pretty good. So based on 2007 OECD data in 2013, they came up with a series of analyses. And you can see there that the United States was ranked 38th. That's from their table. And I put in, based on other data that are contained in the report, the rankings of the various countries that are listed in that table. Sweden, 23, Denmark, 35, Norway, 11, etc., etc. Note the bases of comparison. Although Sweden is 23rd overall, of these countries it has the best infant mortality data. And for infant mortality, you want the smallest number possible, because infant mortality is defined as the number of deaths of infants under a year of age per 1,000 live births. Means if there are stillbirths, those are not counted, but if there are live births, then what number of them expressed as this ratio, that's a rate, die before reaching the first year of age. And that number is lowest in Sweden here, 2.5, and considerably higher in the United States, 6.8. Another number that's used to measure the overall performance of health systems, the overall status of health in the country, is life expectancy. You want that number to be as high as possible. That means that the average person calculated will survive to that age. And so it's 81 for Sweden, and it's 80.6 for Norway, and so on, but 77.9 for the United States. Those differences don't seem significant, but actually they are significant, certainly given the number of people involved and the number of life years that adds up to. That is a significant number. Another measure, the percentage of infants that are born essentially prematurely or with very low birth weight as a percent of the total of live births. And again, we see a distribution with Sweden ranking best at 4.1, and the United States with 8.2. Maternal mortality, that's where you want to have as low a number as possible. That's the number of women who die per year in childbirth or soon thereafter, per 100,000 in this case live births. The number is very low in Sweden, 1.9, and quite high in the United States, 12.7. So those are indicators of the relative performance and quality of various health systems, and by all measures, the United States does poorly, and other countries do far better. And that really comes home with a vengeance when you look back to page 1 of the handout. There you see that though the United States performs less well by a considerable margin than many of the countries which are arrayed below it, it spends, this is again based on slightly out-of-date data, but the best that we could collect for this, 2012, and at that time, and the number has risen, over $8,200 per capita on average. That is, you take all the expenditure and you do a calculation based on the population. It comes out to $8,200 roughly per capita then, whereas other countries spend considerably less. But those other countries, if you've already been able to put the data together, perform often considerably better. So switch to now page 2, and you can go back and forth between these two tables, and you realize that in terms of infant mortality, remember we want the lowest number. These data are slightly different, it says 6.7 instead of 6.8 for US infant mortality. But you notice the United States, which spends the most overall, has the worst infant mortality. It also has, on a little table, the worst life expectancy and other things. And Sweden, Finland, Norway, etc., which spend less, sometimes considerably less, have much better infant mortality rates. So what's going on here? Well, the full set of information provided by the Institute of Medicine gives us some additional numbers. They have a very interesting table. They rank all the 184, I believe it is, 190, sorry, countries which belong to the World Health Organization. There's probably the same number of countries that are represented in the UN in the world, so that we have at the very bottom the Democratic Republic of Congo, Central African Republic, Burma, etc., Malawi, Mozambique. And in the higher numbers, we have other countries, with the United States coming in at 38, because these are organized by ranking. So the general ranking is in the left column, 1 for France, 9 for Austria, 15 for Iceland, and so on. And then there's another ranking that is expenditure per capita, not the actual number of dollars, but the relative ranking of how much is spent. So France comes in at number 1, and they are number 4 in terms of expenditure per capita. So that may have some intuitive appeal. They do so well because they spend so much. If they're the country which puts in 4th best per capita investment, they're getting a good bang for the buck. Similarly, Japan. comes in ranking at 10 overall and is 13th in terms of per capita investment. That makes sense. Iceland, almost perfect. 15th in overall ranking, 14th in overall investment. Sort of the way you would expect it to be. Then you come into the vast discrepancy in the United States. 38th in overall ranking, 1st in overall expenditure, and as we will see as the course proceeds, by a considerable margin. It's not even close how much we, in effect, overspend on healthcare. So why is this? This is the first thing we have to pause and reflect on. The basic reason is that spending money on healthcare is not, as common sense would have it, necessarily going to lead to the best health outcomes. Why? Because, for starters, we may be spending wastefully. Another very important factor is that we may be spending on the wrong things. We may be investing in very expensive, high-cost technology, and in terms of overall impact on national health statistics and rankings, those investments affect a relatively small number of people, and the money that's invested in high tech for a relatively small and privileged number of people, in terms of a nation's overall health data and health ranking, might be better spent, better distributed, if it were invested instead in other things, in basic social services, in preventive measures, in efforts to transform people's dangerous habits and behaviors about smoking or taking in excessive amounts of substances which are harmful, and so on. And if the resources were more evenly or wisely distributed, the same amount of spending might result in better outcomes, or even a lesser amount of spending might result in better outcomes. So what we can say about the United States, for starters, is that it is spending more and getting less in terms of measurable outcomes than other countries. And that has to be a central focus of the course. Why is it? How is it? Where is it that we spend more and get less? What do other countries do? What other priorities do they have that might make their investments in healthcare more efficient? Now, this is already poking at what's going to be one of the major themes of the course, which is going to be to question common sense. Well, you might say, it's just common sense that the more you invest in healthcare, the better the results are going to be. And it's also common sense that the United States has, without question, technically, the best health care there is. In fact, wealthy people from all over the world, from the Middle East, elsewhere, will make medical pilgrimage to the United States to get care at the Cleveland Clinic or the Mayo Clinic or Johns Hopkins or wherever, because they know, as the world knows, that the U.S. has absolutely top-rate, super medical technology, and that's what they need to become healthy. That's common sense. So if we have, without question, the best technology as measured by this universal appeal that the United States seems to exercise, and if we invest so much of our national resources in healthcare, of course we have the best healthcare system in the world. It's just common sense. Well, I'm going to ask you, starting today, to do what I call interrogating common sense. Looking at it hard. Trying to think of other ways of taking the data in and relating them. Realizing that common sense may really be a myth or something that we have been socialized into, less polite way of saying it, brainwashed into believing that if we just invest in technology, we just invest resources, we are going to get the best results, and that's all we need to know. Interrogate common sense, starting now, and you may come out with very different understandings about what really is going on in our health system. And we will be coming back to this question of interrogating common sense. I'm going to, starting next week, present some key examples of what I think is our commonsensical belief and set of associations, and then try to question them one by one until we realize that every time we think we understand and we know it because it's just common sense, we should really stop, pause, interrogate, and look at things differently. But before we get to those specifics, and I'm just sort of whetting your appetite, I want to get to three other basic issues that are introduced and discussed in the first set of readings in She and Sing, our textbook, that are on the syllabus and that were supposedly, I guess, for last time, but they're really going to be discussed now, and we may even lap over a little bit into next time. Pages 40 to 55. There are, I think, three fundamental issues which are raised in those pages. I want to lay them out and then look at them more in detail as time permits. First basic conclusion from reading those pages is that how our U.S. health system fits in with our cultural values and perceptions and expectations is a central issue. Or to put it another way, what we have in the United States is an American health system. It is not just a generic health system. There really is no such thing as a generic health system. There are, of course, similar components, hospitals, doctors, et cetera, in all good health systems. But there's no such thing as one generic health system that you take off the shelf and insert it into a national context. In fact, each country's health system reflects, in basic, subtle, and fundamental ways, that country's history, values, ethics, etc. And so, what we have in the United States, as in the title of this course, the U.S. health system, is an American health system, reflecting our values, including our confusions, our conflicts, our very different perceptions of what's right or wrong and needs to be done. And to just give you a little taste of that, I'll call your attention right at front to a cartoon that begins this chapter on page 39. Chapter actually begins on page 40, but just, that's the text. But in the page before, Beliefs, Values, and Health, there's a little cartoon at the bottom of the page which speaks volumes. And if you don't have the book to refer to it now, you should look at it soon, but I'll try to describe it to you. I'll paint you a word picture of it. It has a large, modern-looking building which is labeled U.S. Healthcare. And there is a front entrance with an awning, nicely appointed front entrance, where people are striding in who seem to have the right to be there or the sense that they have privilege to be there. That's where they should go in, the front entrance to the U.S. health system. And in the back, sort of where the garage might be, where the trash might be collected, in some less prestigious and less landscaped entryway, there is another entrance to the system, which says, trying to read it now, charity, yes, very important. So U.S. healthcare system, where those who have access with money or ample insurance can stride in, can come in the front door and get all the benefits of that very nicely appointed and organized and architecturally impressive structure. If you don't have resources, and the only way you can get some kind of care in that institution is by means of charity, because you don't have the means, and we're going to be talking about what that means and what that means in terms of access to emergency care and so on, that'll all come up. You have to go to the back door, to the decidedly less appointed, less attractive entrance. And the person at front who is pointing to someone who looks like he or she is on crutches, has some challenges, and can't go in the main entrance, but at best may be seen after who knows how long a wait in the charity, through the charity entrance. The person points very decidedly and says, "This is the market justice system. Social justice is over there." Powerful cartoon, powerful message, which says that the U.S. system seems to be guided by some conflict in values. The predominant set of values that govern the access and behavior of the better off people, those who are more well off, are guided by the market justice system, which presumes that if you have the means in a competitive market, you can get the services. You can buy the commodities. Healthcare seen here as a commodity. It is not a right. If this were a hospital in, let's say, Sweden, which is committed to the notion that healthcare is a right, there's only one entrance. Everybody goes in the front door. But this is not a Swedish hospital. This is not a Swedish system. This is a U.S. system. So we differentiate between people with means and people without. And the only sort of afterthought, if you need care, maybe you can go to the back end of the hospital and pick up some care there. If you're willing to put up with the indignities and the interminable waits and all the rest of it, if you don't have the means, we'll give you some charity, we'll throw that at you. And that's perfectly okay, because we have this conflict of values. Some people in the United States who believe strongly in a social justice model, so we give them a little bit of acknowledgement and create this sort of afterthought social justice system. That's why, as we will see, when efforts were made to produce health reform in the United States, and reformers, including as recently as President Obama and his colleagues, tried to reform the American health system, they ran into deep fundamental American commitments to a market justice system. If you have the means, if you are well enough employed and your employer covers you, then you get access and full benefits to the American health system. Otherwise, we either don't care, or we're blind and see no problem, or maybe if forced to do it, we throw you a few coins as charity, and maybe create a poorly funded charity-like program for the poor called Medicaid to let you gain access. But when did we create Medicaid in the United States? Only in 1965, after more than a half a century of struggle to get a universal health system, and after many other countries achieved them and incorporated health care as a right in their national constitutions, countries like Sweden, for example. In the United States, we only reluctantly got to a poorly funded charity program for the very poor, and we funded it so poorly that Medicaid, one of the hard things to realize, doesn't actually cover the majority of the poor, because the levels of financial qualification for Medicaid are set so low that before Obamacare, and not only in certain states, Even if you are at the defined federal poverty level, which is very low and very hard to get by on, you in some states earn too much money, even at the poverty level, maybe twice as much, or 3 times as much, to qualify for Medicaid. For Medicaid was only for the very, 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 very bottom. That's some attempt to insert social justice, but the US system has these 2 entrances captured in that cartoon, and that's why it is a US system and not a generic system that's been plopped into the United States. And everything about it presumes American values and American privileges and American perspectives. Even though there is no consensus, as we know, our country is bitterly divided, there are some dominant views, and those dominant views, at least as represented in our legislative bodies, take precedence and seem to define basic policy. And we're going to be sorting our way through it. Okay, that's number one takeaway from those first 15 pages, 40 to 55. What's another basic takeaway? Well, our health system really isn't a health system at all. It is called a health system only by misnomer. It is really a system, hospitals and all the related professionals and related institutions and so on, is all about taking care of sick people. Sure enough, I'm very grateful for that. I'm very grateful for the quality of care and the mercy and the tenderness that's expressed in taking care of sick people. But let us acknowledge that it is not a health system, it is a sickness system, by and large. There are certain dimensions of our health system which try to promote health, but they are of a very decidedly secondary nature. It is maybe a medical services system. Even the notion of health services is typically a misnomer. What we're talking about when we talk about health systems is really about a sickness or a medical services system which is only in small part aimed at promoting health and providing health supporting services. Tied in with that is yet another important point that's made in those first 15 pages, that we in the United States, I think especially, there may be many others in other countries in the world, who make a very simple, logical, and emotional error when they think of ways to improve health in the United States. What they really think about are ways of promoting medicine or medical services, rather than thinking about other factors that might improve the health of populations. And we tend to, when we look at media, when we read magazines, when we see stories on television, our focus has been conditioned to concentrate on the new advances from the advancing scientific frontier. New breakthrough, this kind of drug, this kind of vaccine, this kind of high technology that will provide better and better imaging and monitoring of what's going on in the interior and so on. And we say that these are health advances. These are contributions to advancing health, but what they really are contributions to advancing medical science and the provision of medical services. There are other things which can contribute significantly to health, and they have to do with other factors that also begin to become clear in the chapter. Let me start with some specific passages so that we can be together on the same page as we proceed. On the bottom of page 40 bottom left column, top of page, same page, 40, right column, is the following elaboration of essentially the message of the cartoon. This chapter explores the issue of equity in the distribution of health services, using the contrasting theories of market justice and social justice. U.S. healthcare incorporates both principles, and I would argue in a confused and really not worked out way, but both principles are there, which are complementary in some ways, but also create conflicts in other ways. The Affordable Care Act, the ACA, tilts the system more towards a social justice orientation, places a greater emphasis on preventive services, but does not quite promise to achieve equitable access to health care for all Americans. All this is true. And when you reflect on some of the debates that have been going on about repealing the Affordable Care Act and replacing it with something wonderful, as our president has said, although the Republicans haven't been able to come up with anything at all at this point, you have to begin to really think about these things. If the Affordable Care Act was aimed more at equity and achieved greater equity and social justice, then is it true that those who are opposed to it are against equity and social justice and just believe in the rule of strength and competition? Let the strong win and the weak be damned? Is that what they believe in? Seems to be. Is that what they say? No, but is that what it really comes down to? And we have to look at those fundamental issues. This is again a reflection of our country with its confusions and conflicts and very incompletely worked out sense of common national destiny and national focus. What are some other things that we can see on those early pages? Page 41, left-hand column. In the United States, the concepts of health and healthcare have largely been governed by the medical model, more specifically referred to as the biomedical model. The medical model defines health and the absence of illness or as the absence of illness or disease. Seems simple. If you define health as the absence of disease, you consolidate the medical model. But is that really an adequate definition of health? Is someone who does not have some major or even troubling disease now healthy? Or is health measured by some other set of criteria? The ability to flourish. The World Health Organization confronted this problem when it was writing its founding constitution, its charter, in 1948, and included in that charter a famous preamble in which the World Health Organization said, and this is the language of the World Health Organization often quoted, health is more than the full language is, health is the state of complete mental, physical, and social well-being, and not the mere absence of disease or infirmity. If you define health in the medical model, if you have absent disease, you have health. The more affirmative World Health Organization definition is, no, we want a state of well-being that applies to all dimensions of life. Social, behavioral, mental, physical well-being. And there are things that we as a nation and as individuals can do to promote well-being which prevents people from coming down with many illness conditions. Not always. Sometimes stuff just happens and there is no way of preventing it. But we can certainly fortify people and strengthen them to deal with the challenges and accidents of life by becoming as healthy as possible, and that means promoting health, promoting a state of physical, mental, and social well-being and not merely trying to keep a disease away or to remove a disease once it is present. So this is also what the authors are calling to our attention. Let me shift to page 54 and some other important items that are included in this chapter. The authors there say that despite the fact, right-hand column, about a third of the way down, despite the fact that medical care compared to the other three factors, and we'll talk about the multifactorial model of health, has the least impact on health in American and well-being. Despite the fact that it has the least impact, American attitudes towards health improvement focus more on medical research, development of new medical technology, spending more on high-tech medical care, and yet we know for a fact, historically, that significant declines in mortality rates, which means improvement in health, were achieved before the modernization of Western medicine or the escalation of medical care expenses. And what they are referring back to is this very important model, which is attributed to an author, Blum. It's called the Blum model, the force field model for health and well-being. It's a simple diagram. Essentially, it's an oval. In the middle is health or well-being. Social, somatic, psychic, that's reflecting the WHO multi-factorial definition of health. And there are, they say, 4 basic contributing factors that promote health. Heredity. Can't control that. You're born with it. But your heredity has a very important influence on your ultimate health history and health status. Environment, very broadly defined, including the physical and the natural environment, the environment as we normally think of it, but also, they deliberately tell us broadly, the socio-cultural environment, the economic environment, the educational environment, the employment environment, anything that's outside the individual, in effect. The environment, social, physical, etc. That contributes significantly. One's own lifestyle, behavior, habits contributes. And then the fourth vector, the fourth force field, is the medical care services. Prevention, cure, care, rehabilitation, etc., the normal medical contributions. And what the authors say, based on Blum, is that contrary to common sense, the factor which contributes least to overall health, both individual and collective, national population health, is medical services. And the factors which contribute more significantly are heredity, lifestyle, and very significantly, environment. Broadly, the social and physical environment. These are far greater contributions to health. So their statement is, despite the fact that we have this model and a lot of supporting data that gives it grounding, that says medical services, medical care, medical technology, medical science, though important, is the least important contributing to overall health, we have a tendency as Americans to attribute all major advances in health to some technological or scientific or medical intervention, rather than looking to environmental changes or these other kinds of changes that are actually present and influential. So we're going to have to stop here. I recommend that you strongly read about the Blum model, read the pages around it, and to begin to consider ways in which you've absorbed as common sense a set of assumptions that now need to be interrogated. And we're going to have to stop here.